Today we're tackling the most misunderstood, fear-mongered, and potentially life-changing topic in menopause, hormone therapy, also known as menopausal hormone therapy or MHT. If you've ever been told it's too dangerous, too complicated, this episode is for you. We're going to untangle the infamous Women's Health Initiative study that scared everyone, explain what modern hormone therapy actually looks like, and arm you with the facts you need to have an informed, confident conversation with your provider. What is hormone therapy, and why is it so controversial? Menopausal hormone therapy is exactly what it sounds like, replacing the estrogen and sometimes progesterone your ovaries stopped producing to relieve symptoms and protect long-term health. It's been around for decades. In the 1990s, it was prescribed widely. Then came 2002. The Women's Health Initiative, or WHI, a massive government study, dropped a bombshell. They announced that hormone therapy increased the risk of breast cancer, heart disease, stroke, and blood clots. Women and doctors panicked. Prescriptions plummeted overnight. Millions of women quit cold turkey, suffered through severe symptoms, and never looked back. But here's what nobody explained clearly. The WHI studied older hormone formulations, oral conjugated equine estrogens from horse urine, and synthetic progestins in women who were on average 63 years old, many of whom were decades past menopause, already had cardiovascular disease or risk factors, and were given hormones for the first time at that late stage. The risks were statistically significant but small in absolute terms, and they were most concerning for older women. In the years since, a massive body of research has clarified the picture. For healthy women who start hormone therapy within 10 years of menopause or before age 60, the benefits often outweigh the risks. Modern formulations use body-identical estradiol and micronized progesterone, which are molecularly the same as what your ovaries made, and have better safety profiles than the older drugs. Delivery methods include patches, gels, and creams that bypass the liver and reduce clot risk. The sloth manager who now runs your body is saying, "I can work with this." Let's discuss what makes sense for you. Let's sort reasonable candidate for hormone therapy from should avoid or proceed with extreme caution. Good candidates for hormone therapy. Healthy women within 10 years of menopause or under age 60 with moderate to severe hot flashes, night sweats, or other symptoms that affect quality of life. Women at risk for osteoporosis who can't tolerate other treatments. Women with early or premature menopause, before age 40 or 45, who need estrogen to protect their hearts, brains, and bones until the natural age of menopause. The benefits for these groups include symptom relief, bone protection, reduced fracture risk, and potentially reduced cardiovascular risk and improved cognitive outcomes when started early. Cautions and contraindications. Women with a history of estrogen-sensitive breast cancer, endometrial cancer, active liver disease, previous blood clots or stroke, or unexplained vaginal bleeding. For these women, non-hormonal options like certain antidepressants, gabapentin, cognitive behavioral therapy, and vaginal-only estrogen for dryness are available and effective. Also, if you have a strong family history of breast cancer or carry the BRCA gene, you'll need a more nuanced conversation with a specialist. The rule: hormone therapy is not one size fits all. It's a personalized decision made with a knowledgeable provider who looks at your age, time since menopause, medical history, family history, symptoms, and personal preferences. Anyone who says hormones are poison for everyone or hormones are miracle drugs for everyone is wrong. The truth is nuanced, and you deserve nuance. Now, how to navigate the hormone therapy decision like an informed advocate, not a confused patient in a paper gown. Tip 1. Know the types. Systemic estrogen is for whole-body symptoms like hot flashes, night sweats, bone loss, and mood shifts. It comes in pills, patches, gels, sprays, and a ring. If you have a uterus, you must also take a progestogen, micronized progesterone or a synthetic progestin, to protect the uterine lining from cancer. If you don't have a uterus, you only need estrogen. Local vaginal estrogen is for genitourinary symptoms like dryness, itching, pain with sex, and urinary frequency. It stays in the vaginal tissues and doesn't treat whole body symptoms. You can often use both systemic and local if needed, or just one. Tip 2. Timing matters. The window of opportunity hypothesis suggests starting hormone therapy within 10 years of menopause or before age 60 offers cardiovascular benefits and possibly cognitive benefits that are lost if started later. This is not a hard deadline, but it's a consideration. Don't wait until symptoms have destroyed your quality of life to start the conversation. Tip 3. Bring data to your appointment. Track your symptoms for a month. Write down your hot flashes, sleep quality, mood, pain, libido, and any other concerns. Bring your family medical history. Ask your doctor, based on my age, time since menopause, medical history, and symptoms, am I a candidate for hormone therapy? What are my absolute risks versus benefits? Use the word absolute. It changes the conversation from scary relative risk percentages to real numbers. Tip 4. If your doctor dismisses you, find a new one. The North American Menopause Society has a provider directory. Look for a certified menopause practitioner. Many women see a gynecologist or a menopause specialist for hormone therapy, not just their primary care provider. You're not being difficult. You're being your own best advocate. Tip 5. Reassess regularly. Hormone therapy is not a start-and-forget treatment. You and your provider should reassess annually. How are your symptoms, any side effects, new risks, and whether you want to continue, adjust, or taper off. The goal is the lowest effective dose for the appropriate duration. For most women with bothersome symptoms, that's several years, not forever. So, hormone therapy is not a terrifying one-size-fits-all danger bomb. It's a nuanced, personal evidence-based tool that might significantly improve your quality of life, protect your bones, and support your long-term health. Or it might not be right for you, and that's okay too. The point is, you deserve the conversation, not a dismissal. You deserve informed choice, not fear-mongering.